A very good afternoon. I welcome you all from the Department of Anesthesia and Critical Care for the CME. So basic target would be to know more about difficult airway. We'll be starting with the definition of difficult airway, go on to the theoretical aspects of algorithm, and discuss a couple of case scenarios on how to manage the difficult airway. I would like to welcome our moderators today, Dr. Harish, Dr. Sanjay, and Dr. Murugesan sir to come up. You can come up on the stage so that you can moderate. The CME is being recorded over the Zoom. I think the link is shared so that you can share with your friends as well. Let's begin our first CME. Thank you.
Good afternoon. Good afternoon. I'm Dr. Rakesh from the Department of Anesthesia. I'm working at MSH. I'll be taking the topic airway assessment. Can you hear now? Hello? 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 Am I audible now? Yes. Okay. So I'll be covering the topic airway assessment. It will be divided into the 4 parts: introduction, history, examination, and advanced airway assessments. Expertise in airway management is essential in every medical specialty. Maintaining the patent airway is essential for adequate oxygenation and ventilation. Failure to do so, even for a brief period of time, can be life-threatening. The main respiratory-related injuries are inadequate ventilation, esophageal intubation, and difficult tracheal intubation. Difficult tracheal intubation accounts for 17% of respiratory-related injuries and results in significant morbidity and mortality. Why we need to assess the airway? That is because recognition of a potential difficult airway allows for optimal preparation, proper selection of equipment and technique, and also participation. We can ask for help, participation of personnel who are experienced in management of difficult airway. History-wise, there are congenital causes: Pierre-Robin syndrome, Treacher-Collins syndrome, Goldenhar syndrome, Down syndrome, Klippel-Feil syndrome, goiter. I have shared 2 images. The first one is Pierre-Robin syndrome. In that, the main significant part is the retrognathia. The lower jaw is very small. Because of that, the tongue becomes very large, appears very large, and the axis alignment for laryngoscopy and intubation becomes difficult. So it's a difficult intubation. By seeing the children's faces, we can make out that the child has Pierre-Robin syndrome. The second image on the lower part, which I have shared, is Klippel-Feil syndrome. In that, there is congenital fusion of the cervical vertebrae. So because of that, the patient will have a very short neck, as well as the extension might be affected. Same is true for difficult intubation. Acquired causes, there are many. Some of them are the laryngeal edema, croup, which can cause edema in the larynx. Abscesses, Ludwig's angina. These can cause distortion of the airway plus trismus. Rheumatoid arthritis can cause restricted mobility of the C-spine and temporomandibular joint. Ankylosing spondylitis can cause lack of mobility of C-spine. In children, sometimes we see cystic hygroma, which can cause stenosis or distortion of the airway. The image that I've shared here is rheumatoid arthritis with the C-spine being fixed. The patient's head is not reaching the bed. In this condition, it's a difficult intubation. Other causes in acquired, which are facial injury, C-spine injury, these can cause edema, hematoma, unstable fractions, the bones. Obesity is a difficult area in the view that it has a short, thick neck, redundant tissue in the oropharynx, which makes it difficult for intubation. Hello. Acute burns can cause airway edema, which is also difficult intubation. Acromegaly can have, sorry for the spelling error, it's macroglossia and prognathism. These acute burns, facial injury, these can also be a difficult mask ventilation, because of which oxygenation can be difficult in this patient. Examination, the most commonly used test that we do in an elective situation is the Malampati test. In this, we ask the patient to, in a sitting posture, keep the head erect and open the mouth as wide as possible with the tongue protruding. Actively not to phonate, not to make the noise when they open the mouth. And based on what are the structures that we see, it's classified into 4 grades. First grade, we see the tonsillar pillars and complete uvula. In grade 2, part of uvula is obscured. Tonsillar pillars are not seen. So soft palate and hard palate are seen. In grade 3, soft palate is seen, uvula is not seen, and hard palate is seen. In grade 4, only hard palate is seen. This examination generally it makes us realize what is the relation of the tongue size to the pharyngeal size. Atlanto-occipital joint extension. This is the feasibility to make sniffing or magal position for intubation. Patient to hold the head erect and neutral, and then asked to extend the head maximally without extending the neck. The angle traversed by the occlusal surface of the teeth is measured. Normal is 35 degrees and higher. So grade 1 is greater than 35 degrees. Grade 2 is 22 to 34 degrees. Grade 3, 12 to 21 degrees. And grade 4 is less than 12 degrees. Grade 3 and 4 predisposes to difficult intubation because visualization of the larynx via normal laryngoscopy is not possible. So we might have to use additional equipment or newer video laryngoscopes in such patients. Okay, another thing that we usually see in every examination is the thyromental distance. Normal is 6 centimeters. That's the distance between from the mentum to the thyroid cartilage. It's also called Bartle's test. It assesses the difficulty in aligning axis. If it is less than 6 centimeters, again, the axis alignment between the laryngeal axis, pharyngeal axis, and oral axis is difficult. Interincisor different distance is the distance between upper and lower incisors. It assesses the mouth opening, which is our way for intubation. Upper lip bite test. This assesses the ability to protrude the lower jaw. We ask the patient to bite the upper lip with his lower teeth. So grade 1, grade 2, and grade 3. First, grade 1 means the patient is able to bite the vermilion border of the upper lip. Grade 2, patient's lower teeth is not able to reach the vermilion border. And grade 3 is he's not able to protrude the lower jaw beyond the upper jaw. This helps in assessing for intubation as well as mask ventilation. Mask ventilation will not be able to give a jaw thrust in such patients who are grade 3. The last one is during routine laryngoscopy, what is the laryngoscopic view that we get? It is named as Cormack-Lehane grading of laryngoscopic view. It assesses the extent of visualization of the glottis. In grade 1, the entire glottis, including the anterior commissure to the posterior commissure, is seen. In grade 2, the anterior commissure is obscured. So middle third to posterior third of the laryngeal inlet is seen. Grade 3, no part of the laryngeal inlet is seen. Arytenoids may be visualized, and epiglottis is the main structure that is visualized. In grade 4, even epiglottis is not visualized. Okay. In advances, generally difficult airways, we do radiography to assess the position of trachea and CT scans for tumors and masses in the trachea or oropharynx. The newer advances is 3D modeling to visualize the trachea, upper airway, and the masses which are protruding into the airway through the 3D modeling. Our head and neck department routinely does this nasoendoscopy. So under local anesthesia, with the patient awake and breathing, they insert a small fiber optic scope through the nares and assess during patient when he's breathing also how the airway is moving. So this will be a more dynamic evaluation of the airway. And third one is the ultrasound. Ultrasound can be used for pre-airway management, intra-airway management, and post-airway management. Pre-airway management, we can assess the the thickness of the tongue, which correlates to our Malampati classification. So relation of pharyngeal volume to tongue volume can be assessed. During the process of intubation and this one, we can visualize whether the tube is in the trachea or not with ultrasound. Post procedure, we can see if the tube is in position 1. Second, any other masses occluding below the tube if the tube is not reaching. Another advantage of ultrasound is for management during tracheostomy to tracheostomy or emergent situation where we can identify the cricothyroid membrane easily with the ultrasound. And in obese patients or patients with airway edema, neck abscess and all, to identify the trachea itself to the tracheostomy. Clinical pulse, what we usually do during the elective airway examination, the Malampati test, the upper lip bite test, and barometric distance. One measurement between the thyroid and the hyoid. So thyroid distance is usually missed. This distance is important because if that is less than 3 centimeters, it usually predicts a very anterior airway, giving a Cormack-Lehen view of 3 or 4. Thank you.
I call upon the next speaker, Dr. Shweta, to present.
Good afternoon, everybody. Greetings from the Department of Anesthesia. I'm Dr. Shweta, and I'll be taking you through the difficult airway guidelines today. Now, airway management is one of the core competencies of any anesthetist. So, difficult airway and that kind of scenario is pretty dreadful for anybody. Next. Yeah. So difficult airway scenario looks something like this. There's a general palpable tension in the atmosphere. The person at the head end is breaking a sweat. The assistant looks frozen and sats are dropping, heart rate is dropping. The other people don't know what to do. They just know something is very wrong. So our guidelines precisely aim at avoiding a scenario like this, or even if we land into one, to try and get out of it with the best possible outcome.
Rajiv, make a slideshow.
So what is a difficult airway? Now, according to the ASA, a difficult airway is difficulty in or
It is not
failure
on
to
slide
complete
2.
any of these sequential steps that we use for upper airway management. So it can be a difficult face mask ventilation, it can be a difficult laryngoscopy, difficult or failed intubation, difficult supraglottic airway, or difficult extubation. Now, in spite of all these tests, why do we land up in a scenario like this? The reason is that none of the tests are sensitive enough to accurately predict for an average risk patient. So anticipated difficulty, we can all, try and do all these tests and make out. But unanticipated difficulty is always there somewhere around the corner for us. So we have to be prepared for this. So our guidelines aim precisely at that. So the guidelines I have chosen is the IDA guidelines that is formulated by the Indian association, that is All India Difficult Airway Association. Now, the reason I've chosen this is because there are lots of guidelines actually. There are the DAS guidelines, there are ASA guidelines, and lots of them. Now, this is more robust, it is more simpler, and a thorough literature search has gone into this. It's not just a rehash of whatever was existing up until the time this was formulated. This was formulated sometime in 2016, and this was published later in the Indian Journal of Anesthesia. So they've not just given us one guidelines, they've given us the 5 different guidelines. One is for unanticipated difficult airway in adults, which I'll be dealing with mainly. They've also given us difficult guidelines for obstetrics, for pediatrics, and probably for the first time in the world, the intensive care as well. So they have some disclaimers. Know what exactly is a guideline, the guideline. Guideline is a statement which determines a course of action. That is, it just streamlines a particular process according to a set routine. So they make our actions more predictable and presumably of better quality. What we have to remember here is following a guideline is never the law. It's never mandatory. And they do not represent the minimum standard of care, or are they substitute for good clinical judgment. What I mean by this statement is, supposing the guidelines ask you for an invasive airway, but you've never done it before. You're cutting the neck is not very, pleasant for anybody. So if you're confident that you can put together a bronchoscope in less than a minute, you have a good team, you can go ahead with it. That's your clinical judgment and you can still go with it. You don't have to stick to the guidelines and say, I have to go for an emergency airway now because that's what is mandated here. Now, how do the guidelines look like? The guidelines look something like this. It's very simple. It's a straightforward flow chart. Unlike what the ASA has, the American Society has more branch pattern. It's more difficult to remember. This is simple 4-step approach. So let's go on to this step by step. So this is for unanticipated difficult airway in adults. Okay, so what happens is, in the step 1, you've taken the patient in, you've induced the patient and done a laryngoscopy, and you're not able to intubate. So that is where the panic starts. Okay, so the minute you have not been able to secure an airway, like in all difficult scenarios in life, just call for help first, and then move on to the next step. Move on to the next thing in the flow chart. So call for help, and then you're allowed 2 more attempts at securing an airway. That is 2 more attempts at intubation here. So what the more unique feature of IDA here is that they stress more on peri-intubation oxygenation. See, before inducing a patient or before you plan for intubation in other settings, we always pre-oxygenate a patient, right? So 3 minutes of pre-oxygenation is mandatory. But what IDA says is another route of giving oxygen, that is by nasal cannula of about 15 liters, they have suggested. This is what prolongs our safe apnea time. So peri-intubation oxygen is mandatory, and that has to be continued up until the time we secure an airway. And again, another 2 attempts is not just the lifelines that we have when we go on intubating. Between the attempts, we should always make sure that saturation is more than 95%. And also, we have to do something different. If you used a regular laryngoscope, try and use a video laryngoscope the next time. So change something, change the operator, or change the technique, or change the device that you've used. So with all this, if you're able to, secure the airway, it's good. So IDA recommends using a waveform capnography to confirm the intubation, because in between the attempts to intubate, aggressive mask ventilation can inflate the stomach. So don't respond to a single trace. So try to have about 5 or 6 consistent traces with no decline. If the tube is in the stomach, there's always a decline, and so that can alert you about esophageal intubation. So for some reason, you're not able to, intubate with these 3 attempts that you've been given. So there's 1 failed attempt and 2 attempts afterwards. So if you're not able to intubate, move on to the next step. Don't get fixated on that step and just go on trying more and more. So the second step is the supraglottic airway device. Now, what these supraglottic airway devices has done is they have moved us away from this intubation-centric management to more ventilation-centric and oxygenation-centric. That is, it is no longer important to just get the tube in. It is important to oxygenate the patient. So what you do is try to use a supraglottic airway device. Now again, continue using the nasal cannula at 15 liters. And this, when I say supraglottic airway device, what do you use? There are so many in the market. So preferably it is better to use a second generation supraglottic airway device. So why second generation again? The reason is they always have a, anybody? They always have a, they have a gastric drain. So we can always insert a rice tube and try to deflate the stomach. That in turn will improve our ventilation, right? So that's one thing. And second thing is the ceiling pressure of this supraglottic airway devices is about 30 centimeters of water. When I say 30 centimeters, what it means is if you use a peak inspiratory pressure of about 30 or less, the ventilation is very good. There's no leak around the supraglottic airway device, and for both safety and for efficacy, it's very good. So again, you've been given 2 attempts here. The reason is, according to the Goldman study, only 4% of supraglottic airway devices were placed in the 3rd attempt. So here they've given us a leverage of 2 attempts. Now again, do something different. If you've used a classic LMA, go for a ProSeal LMA or an Ambu or whatever. If you don't have a second generation device, try and do with whatever is available with you, all right? So throughout this again, maintain the depth of anesthesia and you continue oxygenation. Now you're able to secure the airway here. I mean, you're able to put an supraglottic airway device and you're able to oxygenate the patient. So what do you do next? There are 4 things that have been advised. So the first thing is, you think it's not an emergency surgery. You want to plan better the next time around. So you can discuss with your surgeon and wake the patient up. That is the safest. And second thing is, sometimes you think it's a very simple lumpectomy or something which takes less than an hour, and you're confident with the oxygenation that's going on. So in that scenario, just go ahead and finish the surgery and wake the patient up. However, we have scenarios like, laparotomies or emergency neurosurgical cases where you cannot wake the patient up, you have to go on with the surgery, and you also need a definitive airway. So in those scenarios, what the IDA recommends is to intubate through a supraglottic airway device. At no point should you remove the supraglottic airway device. So how do you do this? Now, the best scenario is to have an 9-3 catheter. Now, this is a hollow bore catheter which can go over the fiber optic scope. And we can intubate we can intubate through the supraglottic airway device and place any size tube over it. Again, if you don't have that, with whatever is available, but the intubation has to be done through the fiber optic bronchoscope. And the last one is tracheostomy. If we are doing a head and neck case or all those scenarios where they are anyway going to plan a tracheostomy later on, we can start off with the tracheostomy. There's no hurry here because we are able to oxygenate the patient, right? So we can put together a team, we can get the best possible help and then go on with the procedure. Now, this is the next scenario is quite scary. Now, we cannot put a supraglottic airway device. We have missed the chance of intubation and then the supraglottic airway device placement. So what do you do next? So we've been given one rescue face mask ventilation here. So while we continue giving nasal oxygenation, we have to try and ventilate the patient by using a face mask. Now, at this point of time, again, they ask us to ensure a neuromuscular blockade. This is different from what we have been learning all these days. So it's a difficult airway. We would never give a relaxant. We would try to, make the patient spontaneous and try all those maneuvers. But however, IDA recommends using a neuromuscular blockade because first thing is the neuromuscular blockade will, improve the compliance of the lungs. You can ventilate the patient better. A second thing is, if you've come up to this stage in the airway management, you might have to go in for an emergency cricothyrotomy. So the best chance that you can, for getting a successful cricothyrotomy is in a still patient. So because of both these reasons, they recommend neuromuscular blockade. However, if you're not okay with using a neuromuscular blockade agents at this point of time, we also have good reversals. We can just reverse the patient if we are not able to go ahead. So if you don't want to do that, you can just wake the patient up and plan all this better. All right. However, if there is a complete ventilation failure, this is a term which is, coined completely by the IDA. What complete ventilation failure says is that we are not able to intubate, we are not able to mask ventilate, we are not able to ventilate the supraglottic airway device. So these three are main weapons. We are not able to use them. So, yeah. So we are, this is called as a complete ventilation failure. So here, IDA recommends calling for additional help. So additional help is not just for our technical expertise. At this point of time, I think our cognitive overload is there and we are not thinking straight and, they're sweating everywhere, we are panicking. So that person who comes in can give us a new perspective on this whole scenario. They can just pick on something we've missed. So at this point of time, call for additional help and move on to the next step, which is emergency cricothyrotomy. I think we have a talk on this subsequently, so I'll just keep this to very brief. So here again, continue using the nasal cannula and I mean giving nasal oxygenation and perform whatever that you're comfortable with. You can do a surgical cricothyrotomy or a whiteboard cannula cricothyrotomy or a simple needle cricothyrotomy. The only thing to remember here is if you resort to a needle cricothyrotomy, you have to ventilate through the pressure regulated chest ventilation device because there's a lot of resistance that the catheter can give you. And also keep the upper airway patent to avoid breath stacking. And whatever cricothyrotomy you do, you just transition it to a tracheostomy as soon as you can. And with all these methods, and you somehow gotten the patient to oxygenate, you must have a post-procedure plan in place. And this is also a unique proposition by the IDA. So you must always have a further airway management plan. Like we can't just leave the patient at that point of time. And treat airway edema because if we have come to this part of the flow chart, there is some airway edema that can be anticipated. So try to give a steroid cover and take care of it in the subsequent days as well. And monitor for complications. There may be a lot of bleeding. There may be, some damage somewhere. So try to look for it and treat. And always counsel the patient and document it. So this, if we document and communicate better to the patient, he can become an anticipated difficult airway in the next sittings if he needs the surgery. So just to summarize, what are the unique features of IDA? See, they stress the importance of peri-intubation oxygenation. So like I said, if you pre-oxygenate the patient well, you have about 5 minutes of the safe apnea time. If you add nasal oxygen, nasal cannula oxygen about 15 liters, you can prolong the same thing to 15 minutes. So that is like 15 minutes of breather that we get to do our work there. Again, if it's an anticipated difficulty and we are able to use Thrive here, that can prolong it to up to 40 minutes. So we have 40 minutes of a breather here. So between everything that we do, the IDA recommends having a threshold of about 95%. So if the patient is desaturated, you should quickly move on to ventilating and trying to get the saturation up. Don't use up all your efforts before all your chances before that. And complete ventilation failure, like I said, is a new terminology. See, the DAS guidelines use KAICO and FONA. KAICO is cannot intubate, cannot oxygenate condition. They have gone away from that because complete ventilation failure will precede an oxygenation failure. So at this point, we have a ventilation failure, but we are still oxygenating the patient, right? So that terminology is a misnomer. So they have stuck to complete ventilation failure. And like I said, it's not one, but 5 different guidelines. And calling for additional help during this complete ventilation failure is also a recommendation by IDA. And cricothyrotomy is just based on how familiar you are with whatever settings. It's not the surgical cricothyrotomy like the other guidelines will recommend. Now, these are the DAS guidelines just to show how they look. This is also pretty simple. And like I said, KAICO and FONA. FONA is front of neck access. So only the terminology is slightly different and it is more basic. It's not very detailed like IDA guidelines. And from the ASA, I've just picked up this one because this is quite interesting. So this is for that they've got what is called as pre-airway management decision-making tool. So what happens here is, this is for anticipating a difficult airway. Like for example, you think that you're not able to, pass a laryngoscope, like patient has no mouth opening at all. Or you think the patient has a very high risk of aspiration. You're not able to get in a supraglottic airway device, or for any of these reasons, you anticipate a difficult airway. The safest thing to do is to plan an awake airway management. So go plan the patient well, topicalize the airway, and then use proper sedatives and all these things, and then plan an awake airway management in this patient. If you're successful, fine. If you're not, again you can go in for an elective tracheostomy in this patient again. But everything can be more planned approach. The rest of this ASA guidelines is pretty much what we discussed so far. Now, for the first time, IDA guidelines also recommends, also gives guidelines for ICU management. So the basic outline is the same. I'll just tell you what is different. So the step one is different. They've added a step one here. So how is ICU different from the OT? ICU doesn't have the control conditions that theater has, and it's almost always an emergency airway access most of the times. And we cannot wake the patient up here, right? So if you've decided that a patient needs to be on ventilator, the patient needs to be, we can't wake up and plan better the next time around. So what you have to do is, they recommend having two people in the airway management team, of which one of them is definitely, a senior person and trained in airway management. And again, pre-oxygenation has also been given more importance here. So we can use non-invasive positive pressure ventilation. You can use an ICU ventilator and the mask can give it. And this ICU patients are at, ongoing cardiorespiratory compromise. So what happens is that our induction agents should also be tailored according to that. We can use etomidate or ketamine based on, the patient's condition. So the rest of it is the same. That is, you can go ahead with laryngoscopy. If you secure the airway, fine. Otherwise, go for a supraglottic airway device. And here, if you can place a supraglottic airway device or you can mask ventilate the patient but cannot intubate, you should go ahead with percutaneous tracheostomy or a surgical tracheostomy, depending on whatever you have access at that point of time. So waking the patient here is not an option. Otherwise, the guidelines is pretty much the same. The fourth step has been added, another step has been added here. So there are 5 steps here. Now, there are another groups that we commonly encounter. One is the pediatric and obstetrics. So in pediatrics, these guidelines are for kids up to 12 years of age. Now, difficulty is quite rare, but that is unanticipated difficulty is quite rare, but margin of safety is very narrow. So we can titrate the, intubation according to the child. Like you can keep the head neutral to compensate for the large head. And you can use a shoulder roll in kids less than 6 months. And if at any point of time you have a difficult mask ventilation, try to roll out laryngospasm first. That's more common in kids. But what is difficult here is to get an emergency invasive airway. Now, larynx is more cephaloid in kids. And cricothyroid membrane is very narrow. There's a lot of adipose tissue on the neck. So the procedure is not only difficult, cricothyrotomy is dangerous also in kids. So the procedure of choice, if you have surgical help, is to go for tracheostomy in a difficult airway. The same thing for obstetrics. See, failed intubation is about 8 times more common than our regular population, average risk patient here. Here also we have a narrow margin of safety because of all the physiological changes of pregnancy. So the stress has been on here. In pediatrics, we have only 4 steps, but in obstetrics, we have 5 steps. So the 5th step is, after all these 4 steps, if we are not able to, oxygenate the patient and in an unfortunate event of an arrest, the patient has to, we should start a CPR with a slightly left lateral tilt and conduct a perimortem cesarean in less than 4 minutes. Within 4 minutes. So this is the only changes that are there from the guidelines. So this is a summary of those guidelines that we've talked about. What in any scenario, any place, or any method that we use, human factor issues have contributed to adverse outcomes in about 40% of patients. This is according to the National Audit Project 4. So what it means is that, see, all of us can't be Dhonis. We can't remain calm during a crisis. It's a virtue actually. But we can definitely aspire to be more calm by repeated practice or repeated simulations and all that. So here, non-technical skills are also important as much as the technical skills. When I say non-technical skills, it is how we conduct ourselves in the OT, how we, address each other during a difficult scenario, stop the blame game and try to do what is best and address our intentions very clearly and concisely. This is what I mean by non-technical skills. And also, this fixation error is something we can just get into without our knowledge. So we can easily think, right? If you've done thousands of intubation, how hard can this be? That's a very wrong attitude to have. So if we cannot do it in the first 3 attempts that we have been given, you shouldn't get fixated on the same step and try to get the tube in at any point, any cost. If you just move on, slide on to the next step and try to get these guidelines. So fixation errors will make us lose sight of the big picture. Here, the big picture is to get the patient safe, oxygenate the patient, and you and the patient get out of trouble, right? So that is the big picture. Never lose sight of that. And there are a lot of latent threats that we have, which are more often than not addressed here. See, poor communication. There's a poor, because we wouldn't have started off with an anticipated difficulty. Most problems are in unanticipated areas. Poor communication, poor teamwork, or inadequate processes and systems. Now, to counter this, what we can do is we can just have an airway timeout at the beginning of every case. It's just a minute. It takes a minute to just tell, okay, this is what I've planned. If this doesn't work, I'll move on to the next step and then I'll go on to the next one. So if we have an airway timeout, all these things can be avoided to a large extent. And then again, at the end of a difficult scenario that we've all gone through, we must have a proper team debriefing. So when you debrief, we are better prepared to the next for the next crisis or the next thing that can come around. It can also make us more confident in handling it. Again, not blaming, but having a proper team debriefing. Hopefully, with all this, we can move from a scenario like this to a happy and a cheerful team at the end of the procedure. So, yeah. Just remember that every airway is difficult up until we secure it. So till we secure it, the doubt should always be there. Thank you. Okay, thank you, Shweta, for the extensive debate on that. Okay, so sure. Okay, so my topic is management of tracheostomy emergencies, especially the tracheostomy tube block algorithm. So I'm Dr. Indumati from Anesthesia Department, MSH. So in the next few slides, we'll be talking regarding how we are going to manage the tracheostomy tube block emergencies. Okay, so the tracheostomy emergencies can be categorized into 3 major categories. They are dislodgement or decannulation, obstruction, and bleeding. The dislodgement or decannulation can again be complete or partial, and it's more frequent when the tracheostomies are aged less than 7 days. That is when the stoma is not mature. In an obese or short neck patient, restless, irritable patients, and when the tracheostomy tube is not secured properly. Occlusion. Again, the occlusion can be complete or partial. It can happen because of the mucus plug. It's especially more common when the patient has bad lung, copious secretions, or the tracheostomy care is not good. And granulation tissue. This can happen because of the pressure of the tracheostomy tube tip itself or because of repeated suctioning. Especially if the suction tip is passed beyond the length of the tracheostomy tube, it can injure the mucosa, which eventually can develop the granulation tissue, and that can be complete or partial and block the tracheostomy tube. Clots, again, as we said, because of repeated suctioning or any pathology lower down in the lung can also cause clots. Bleeding. So bleeding can be categorized into immediate causes and delayed causes.
The immediate cause is following the surgery. Usually, as you can see, the anterior jugular veins come in the way of tracheostomy, and they are usually secured and ligated by the surgeon. There can be mild ooze around the tracheostomy site. So this ooze can be controlled by a constant pressure for around 5 to 10 minutes. And the injury to other vessels include injury to the innominate vessel, which can happen as a delayed cause. So the delayed cause is when tracheostomy tube is there for a longer time, say chronic cases. It can cause pressure necrosis over the anterior wall of the trachea and eventually erode into the innominate artery. So that's the right brachiocephalic trunk. So though the incidence is very less, like 0.1 to 1%, it can be catastrophic as it's a major branch directly from the arch of the aorta. The other causes include frequent suctioning and bleeding from above, like in case of epistaxis, and also from the oral cavity, which can trickle down the trachea, and the patient may be coughing it out of the tracheostomy tube. So how do these patients present when they have a tube block or a false track? So usually these patients present with restlessness or desaturation. If the patient is on ventilator, they can have decreased tidal volume, increased airway pressures, and also they can be increased end-tidal carbon dioxide or PaCO2, tachypnea, tachycardia, and hypertension. So before we go to the management algorithm per se, we have to know a few things. Why the tracheostomy was done, when it was done, and what type of tube is used. This is the simple picture of a tracheostomy tube. So you can see that, this is the outer tube. It consists of a cuff and a pilot balloon to inflate the cuff, a flange. This sits on the skin of the neck when positioned properly. And then we have the inner tube. So the use of inner tube is in cases of any block or emergency. We can just remove the inner tube without having to dislodge the tracheostomy outer tube. So there is less chances of losing the stoma. And the last one is the last one is the obturator. It has a blunt tip, as you can see. So the blunt tip aids in easy placement of the tracheostomy tube without having to injure the posterior wall of the trachea. So that is about what type of tube. Tubes can be cuff tube, uncuffed tube, metallic, silicone, or Portex tubes. So we have to know whether they are dual tubes, they have an inner tube or not, how to remove the inner tube. So basic knowledge about what type of tubes we are using on a routine basis have to be there. And when the tracheostomy was done. It's important for us to know when tracheostomy is done because as all of us know, the stoma matures in around 7 to 10 days. Okay, so if the stoma is matured when the displacement or decannulation has happened, then there is less chances that the stoma will close and the chances of false tracking when we try to reinsert the tracheostomy tube is there. And why? Why is the tracheostomy done? So these are some of the indications for which tracheostomy is usually done. We need to know why in case of a block or false track because tracheostomy may be done in case of a head and neck surgery or flap surgery for tracheal stricture, stenosis, or any tumor present. Or even cervical spine surgeries. So in such a situation, if we have to intubate the patient from above in case of emergency, after all the failed steps, then it may be really very difficult. So we have to keep difficult airway gadgets ready by the time we come to that step. And tracheostomy can also be because of ENT surgeries like laryngectomy. Here we have to understand that these are only neck-only breather patients, so there is no patent upper airway. So we can give oxygen or intubate only from the neck axis. So going to the tracheostomy emergency algorithm. As we have for the difficult airway guidelines, there is no single universal guidelines available for the management of tube block, tracheostomy tube block, or false track. Although we have several different local guidelines by different universities proposed, like the Royal College of Emergency Medicine, St. George University, Washington University, and Royal Children's Hospital, Melbourne. And few important ones are the one published by McGrath in Anesthesia Journal in 2012, and the one published in British Journal of Anesthesia in 2020. It was a part of the National Tracheostomy Safety Project. So in the coming few slides, we'll see a few of the algorithms. This one is by the McGrath, which I told is published in 2012 Anesthesia Journal. So you can see that it has a green part and a red part. The green algorithm is for management of tracheostomy in case of patent upper airway patients. So you can intubate or provide oxygen from above. And the red algorithm is for neck-only breathers. So you can intubate or ventilate or provide oxygen only through the neck access. So this algorithm is is published in British Journal of Anesthesia. This again has a tracheostomy green part and a red part for patent upper airway and neck-only breathers. This one is by Dr. Peter Ford, published in the World Federation Society of Anesthesia. So the importance of this is that it delineates the steps for management in case of a new stoma and an old stoma. This one is the one used as a guideline in Royal Children's Hospital, Melbourne. This again by St. George University. So based on all these algorithms, in our hospital, we devised this algorithm, the key points being the same in as it is in the few of the algorithms which we saw before. So in the coming slides, I'll be walking you through the steps we need to follow in case of a suspected tracheostomy tube block or false track, and we'll know what to do. So as in case of any emergency, first step is call for help. Then you provide 100% oxygen. First apply oxygen mask over the stoma and see if there is any improvement in the saturation level or the patient condition, if there is a chest rise. If the patient is not breathing, you can apply gentle ambu bag ventilation. So with this, if there is not much improvement, you can apply a second oxygen face mask over the face. So you can apply 2 masks and see if there is any improvement. Meanwhile, if you have the waveform capnography, you can attach it as it gives the reason for respiratory distress in some of the cases. If any attached valves or filters are like case of speaking valves or HME filters or stopcocks are there, then you can remove them because they may itself be a cause for the obstruction. So you have provided oxygen, but there is not much improvement. Next step is try and remove the inner tube. So remove the inner tube if at all, if anything is present, and see if any block is there, and see if the patient is able to breathe fine and there is improvement in the condition of the patient. If that does not help, then try passing a suction catheter through the tracheostomy tube. So if the suction catheter passes easily through the tracheostomy tube, remove any mucus plug, clots or debris present and see for improvement. The suction catheter passes well, but the patient is not having any improvement. Then you have to rule out other causes like severe bronchospasm, tension pneumothorax, or pneumonia, mucus plugs, which would have caused the condition. So now you have removed the inner tube, you have passed the suction catheter, but the suction catheter is not going. The next step will be to deflate the cuff. So once you, the importance of deflating the cuff is, in this image, you can see that this cuff is completely occluding the tracheal lumen and the tube is partially displaced. And the distal end of the tracheostomy tube is abutting against the posterior wall. So in this condition, again, the patient will not be able to breathe through the trachea, upper airway, and as well as through the tracheostomy tube. So what do you do in this? Once you deflate, then there will be leak around the cuff. So there are 2 conditions in which deflating the cuff is going to help the patient. That is when the tube is completely occluded and the patient is spontaneous breathing, or in the upper case whether it's partially displaced and the cuff is occluding. So what happens, as you can see in the lower picture, the air bypasses the tube and passes around the tube through the patent upper airway, and the patient is able to breathe. If the patient is not spontaneously breathing, you can try gentle ambu bag ventilation. In all throughout the procedure, whenever you are bagging the patient, see that You do not do frenetic attempts at ambu bag ventilation or give excessive bag volume, because if by chance the tracheostomy tube is in a false track, then it is going to cause subcutaneous emphysema, and it will worsen the scenario. So you lose even the existing stoma which is present, and you may find it difficult to insert the tracheostomy tube. Even after this step, if there is no improvement, then the next is remove the tracheostomy tube, close the stoma as shown in the picture with a gauze piece, and ventilate from above with a face mask and ambu bag. If you cannot ventilate, then try and ventilate below from the stoma with a pediatric face mask and ambu bag, or you can even use an LMA and press it against the stoma and try and ventilate. But what if we are not confident that we remove the tube and we cannot reinsert it, okay? Or we are not able to ventilate. So if you feel the stoma is not mature enough and you're not confident enough based on the expertise in which you're attending the case, then you can try intubating the patient with the endotracheal tube from above, confirm the position with a fiber optic bronchoscope, and then go ahead and remove the tracheostomy tube, close it, and ventilate the patient. Or if you're quite experienced, then you can replace the tracheostomy tube directly with a new one. You can use a bougie as a guide, or a fiber optic bronchoscope, or a tracheal tube exchanger as a guide. So once you deflate the cuff and not much improvement, you have three options. One is you ventilate either via the face mask or through the stoma, or else intubate from above, or replace the tracheostomy tube over a fiber optic bronchoscope or a gum elastic bougie as a guide. But while using gum elastic bougie as a guide, just see that you do not push it or thrust it, as it itself can cause a false track or injury to the neck. There are some special considerations like laryngectomy patients. In them, the algorithm remains the same, except that they are neck-only breathers. So they only have the stoma in front of the neck. There is no patent upper airway. So you can oxygenate only via the stoma, and they usually do not have any tube in situ. So you can either put a smaller number endotracheal tube, cuff tube, like 6 number tube, or you can use a smaller endotracheal tube and intubate the patient via the stoma. So how do we prevent such a scenario from happening? So it's always better to secure the tube well. You can tie them well with a 1 finger loose ties, and use of inner tube. So as and when possible, like inner tube can be used whenever the patient is not on ventilator, because you can still use it and keep it in situ. So use of inner tube helps us in case of emergency, because we can just remove only the inner tube, and we can clear it up, and the block is cleared. You need not have to remove the outer tube every time and fear about losing the track. Then use of humidifiers. Humidifiers are going to moisten the air, and because the dry air usually causes irritation of the mucosa, and over a period of time it can cause copious secretions and blockage of the tracheostomy tube. And regular periodic gentle suctioning. As I told, do not pass the suction tip multiple times beyond the length of the tracheostomy tube, so that you can prevent injury to the mucosa. And see that there is no overhanging circuits and extensions. And in an agitated restless patient, see that you restrain the patient or sedate the patients well. And use of the right size tube, especially in case of obese and short neck patients. It's important because in an obese or short neck patients, the neck thickness itself can be 2 to 4 centimeters. So the tracheostomy tube, if the regular one is used, it will be just reaching inside the lumen, and any movement or agitation can make it to come out of the tracheal lumen. So thereby there can be again decalibration happening. So there are several tubes with adjustable flange length, so which helps in keeping the right tube length inside the tracheal lumen. And continuous monitoring. And last is keep backup smaller size tubes and suctions in the bedside always in case of tracheostomy tube patients, which will reduce the time in case of emergencies. And we can also keep a signboard stating when the tracheostomy was done, why it was done, and the emergency contact number in case if any emergency happens. So the key points are: call for help, 100% oxygen, remove inner tube, pass the suction catheter, not possible, deflate the cuff, that's also not possible. You have three options: replace tracheostomy tube over a tube exchanger, or ventilate via the face or the stoma. If that's not possible, then you will have to do surgical neck exploration if the track is totally lost. Thank you.
That they don't. Next.
Good afternoon, everyone. I'm Dr. Abhishek. I work in the critical care department. I thank Dr. Indumati for the previous talk and setting up the platform for my next talk. So I'll be talking about FONA, which is essentially front of neck access. So just before I start off this, I just want to recap from all of you that in total, how many times do we try laryngoscopy and intubation? Just a recap. Is it 2, 3, or 4? How many times do we try laryngoscopy and intubation? 2, 3, 4. 3. Sure, 100%. I need more confidence because what I will be speaking about, you will need a lot of confidence. 3, are you sure? Okay. Yeah. So just to recap, unanticipated difficult tracheal intubation neurals. So as we have already gone through this algorithm, so 3 attempts of laryngoscopy and intubation, failing which will go ahead to try a supraglottic airway device. And if that also fails with oxygenation and ventilation, then something called as a complete ventilation failure, then we have to think about cricothyrotomy. So that is what I'll be speaking about. Yeah, so this is the final step in the complete ventilation failure where you call for help, emergency front of neck access, and this is what you'll have to decide on. So front of neck access is called by different names, IFONA or cricothyrotomy, and this is basically you're trying to access the airway through the cricothyroid membrane. So that is the most important landmark which you'll have to remember and palpate. Technically, even tracheostomy is a FONA, but however, in emergency situations, tracheostomy is difficult. So in emergency, cricothyrotomy is preferred. So ATLS guidelines also suggest the same. Surgical cricothyrotomy is preferable to emergency tracheostomy. This is because it is easier to perform, less cumbersome, and the number of layers you have to go through to get an airway is much lesser. So coming to the history of cricothyrotomy, the 100 BC was the first time when there was a documented surgical airway. 1546, where there was a successful one. 1909, when there was a Dr. Sevilla Jackson, he used the high tracheostomy, which is technically a cricothyrotomy for diphtheria. However, there was high incidence of tracheal stenosis, and this went out of the mainstream. However, in the 1970s, this came back into the mainstream, and today the emergency cricothyrotomy is a surgical rescue technique of choice for a failed airway in adults. Indication, as it's clear, complete ventilation failure, or in a situation where we cannot intubate, neither oxygenate or ventilate. So this situation is we reach when there is intubation failure, supraglottic airway device failure, and all the airway adjuncts have also been tried. So in this situation, as I told you, only available option is aphonia, which is a cricothyrotomy, and failure to recognize a CICO scenario, that is cannot intubate, cannot oxygenate scenario, leads to brain death, leads to brain hypoxia and ultimately death. So some of the situations where we can encounter these difficult CICO situations are oral and maxillofacial trauma, cervical spine trauma where the extension is impaired, profuse oral hemorrhage where the view can be impaired, copious vomiting, again the view and is impaired, and anatomical abnormalities that prevent endotracheal intubation. The most important is unclear or there is no airway plan. So that I think is one of the most important things which we have to consider. So that is why pre-intubation airway assessment is very, very important. And if in case of general anesthesia and OTs, if a CSCO scenario is encountered, we can wake up the patient. But that option is hardly available in ICUs where we have to secure the airway and we have to oxygenate because the indication for intubation will be something else in ICU. It could be severe metabolic acidosis, or it could be shock, or it could be hypoxia itself. So as this is a life-saving procedure, there are no contraindications. Okay, no contraindications. So the most important thing is the anatomy. What we'll have to know. So I want you all to extend your necks and feel this prominence, which is the thyroid prominence, or in colloquial language, it's called as Adam's apple. And as you go down, there is the cricoid cartilage where if you just press a little bit, it will be painful. So that is your cricoid cartilage, and in between these two is a cricothyroid membrane, which is the most important, anatomical landmark for this procedure. So below the skin, this is how it looks: the hyoid bone, the thyroid cartilage. This is the Adam's apple. This is the cricoid cartilage, and this space is what we are targeting for the access. So as we can see, there is the cricothyroid membrane and the muscle. Okay, so these two are important. So as I told you, identifying the CTM is cricothyroid membrane. So that is the most important step. This mainly relies on palpation, approximately 2 centimeters below the laryngeal prominence, and which is superior to the cricoid cartilage. Ultrasound can be advantageous, but we will not have time for ultrasound because, as I was telling you, this is an emergency scenario and the patient's oxygenation will be rapidly falling down. So we don't have time for this. So it's mainly palpation. How do we practice for this procedure? Only thing is just make it a habit to every now and then keep palpating the cricothyroid membrane. So preparation, for the preparation for this procedure is to mainly avoid the situation. So prevention is better than the procedure. So that is the thing. So always have a clear airway plan. Difficult airway algorithm, we all know it, but the most important thing is to follow it. Okay, where all of us know, but how many of us follow it when the actual scenario is happens? That's what is the key. And all equipment should be ready on the bedside. So these are some scary pictures. As you can see, morbidly obese patients, hardly any neck extension is possible, history of trauma, and on laryngoscopy, you see this. So what if this is the third and the final chance where you're intubating and you find this? So often this occurs. I'm sure all cricket enthusiasts will relate to this. This was a famous brain fade moment. So where you cannot think further what to do. So the most important thing is to avoid this. So as I told you, the most difficult step in cricothyrotomy is the cognitive barrier, unable to recognize the CSCO scenario and to take the decision to go ahead with this. So I'm sure all of us would have experienced that once we have a failed airway, we sometimes take it on ourselves that it's like a personal failure, or so this can lead to unacceptable delay in the decision making. Since this is an emergency life-saving procedure, patient counseling and informed consent is not needed. So so once we decide that yes, we have to go ahead and do the cricothyrotomy, position the patient, extend as much as possible, position yourself appropriately. That is, if you're a right-handed person, you have to stand on the left patient's left shoulder. And the non-dominant hand palpates to locate the cricothyroid membrane, and the dominant hand cannulates. So there are different techniques which is described, which I'll be discussing in the next few slides. So these are the general equipments what we'll be needing. A anchor suction because we can expect a lot of bleeding, a scalpel to have a good incision, gum elastic bougie, cuffed 6 size tube, 10 cc syringe, and ventilator with tubing. So we generally need 3 people, preferably a physician, nurse, and a respiratory therapist. So these are the 3 types which are described. So going back, these 3 are the common steps, irrespective of what technique we choose. Yeah, so the same thing, identifying CTM in all patients. This can be more difficult in females because of the more fat and short neck. And there is something called as a laryngeal handshake technique, which I'll be discussing next. So this is the technique where the non-dominant hand uses the thumb and the index finger along with the middle finger to palpate the hyoid bone. So these are the corresponding images. We come down and feel the thyroid cartilage here. And then once we reach the cricothyroid membrane, the index finger of the non-dominant hand palpates this. Okay. So this is called as a laryngeal handshake. And so there was one study which was done, which showed that laryngeal handshake method of palpation is more accurate, but it takes longer. So here time is life, but yes, I mean, identifying that is the most important step. So as I told you, there are 3 techniques which we can use for a cricothyrotomy. One is the bougie-aided cricothyrotomy. This is a 3-step method, standard surgical technique, and needle cricothyrotomy. Yeah, so for the bougie-aided cricothyrotomy, you first give a 3 to 4 centimeter vertical incision through the skin over the cricothyroid membrane. Vertical incision 3 to 4 centimeter. Blunt dissection with the fingers till the CTM is identified. Ignore the bleeding because you expect a lot of bleeding when you're doing this. Already, this is an emergency procedure, so it's not an ideal scenario. So ignore the bleeding. The third step would be to scalpel puncture the cricothyroid membrane horizontally. So remember, the first incision was vertical. The second incision of the cricothyroid membrane is horizontal. This one. This is done on a cadaver, so there is no bleeding. So, and the fourth step would be to slide the gum elastic bougie into the trachea, and the 5th one would be to pass the ET tube, I mean, pass the 6 sizes tube through it, and make sure that the entire cuff enters the airway, and then we inflate it. So the standard technique has 2 extra things. That is, we uses the two extra things. That is a tracheal hook and the trochanteridilator. The tracheal hook is to take the tracheal cartilage and hook it upwards to get a better view, whereas a trochanteridilator is used to extend the horizontal incision vertically, and the same dilator is used to introduce the tube. Needle cricothyrotomy. So these are the steps: palpation, and this is the needle with a pre-filled 5 to 10 ml syringe, which is directed caudally. And as we directed caudally with continuous negative aspiration, once we get the air bubbles, we are sure that we are in the airway. And then again hold it, and then hold the needle at the same place and just push in, advance the catheter further into the airway. And most important thing is never leave the catheter alone, and ventilate the patient through transtracheal jet ventilation. So as I mentioned earlier, needle cricothyrotomy cannot be normally ventilated. You need a high pressure device because the lumen is very small. So there is one more commercially available set, like a tracheostomy set. We also have a cricothyrotomy set where this comes with a pre designed similar to tracheostomy tube and the blade with the guide wire. So here these are the steps for the percutaneous cricothyrotomy. Again, palpation of the and recognition of the cricothyroid membrane using the Seldinger technique. So here, once we insert the needle, we pass the guide wire, and once the guide wire is passed, incision to extend the thing and pass the the cricothyrotomy tube over the guide wire. So here we can see that there is a dilator also. So this has to be inside the tube before we insert it into the neck. So this is the pre-filled thing. And once the tube is inside, we take out the guide wire and the dilator together. That's it. So challenges and controversies, which technique is the best? Is always a debate. So this evidence is limited by because of the emergency situation. It's very difficult to do a study, and all the studies have been done on cadavers and animals. So the best technique is unknown. So these are some of the studies which were generally unconclusive. But what we prefer is the bougie technique. Yeah, so these are the studies. So complications, as I told you, most important is bleeding. So it's expected and should be ignored. You can give pressure or you can pack the site. Other lacerations like thyroid or cricoid cartilage and tracheal rings can be lacerated. False tract also is common. Long-term complications like subglottic stenosis and wash changes are also common. So that is why once we secure the cricothyrotomy, we can leave it only for 24 hours maximum. So this has to be followed by with a definitive airway, preferably a tracheostomy. So the take-home points always have a clear airway plan and anticipate difficult airway in all patients unless we already have a secured airway. Call for help early. So we should please keep your egos aside and call for help early. So recognize cannot ventilate, cannot intubate, cannot oxygenate or ventilate early. Overcome this cognitive barrier and avoid the brain fade. Cut open early. Blood is there to bleed. It will bleed. Don't worry about it. And keep practicing palpation of the cricothyroid regularly. Thank you.
Participating there, difficulty, right? Need a make. Next time. Thank you. Good evening. I'm Dr. Naveen Tagli. I work in the Department of Anesthesia. I think by now you know all the definition of difficult airway, the calls, algorithms, everything. I'll just I'll just now take you through the practical aspects and what are the cases we have done in our department. So before we start, I just want to talk briefly about the assessment of the airway in particular. This is what I mean. Usually I do it, but most of the cases there is something called three-column theory. This was introduced by Greenland. He's a New Zealander in the year 2008. This helps not only to assess the airway, as well as it helps to choose the device which is required, I mean, which is useful for that particular difficult condition. So as per him, there are three columns. One is the posterior column, which is your cervical spine, and the middle column, which is the air passage, and the anterior column. Anterior column is a triangle-shaped pyramid which contains submandibular space, glossal muscles, and the laryngeal skeleton. So as you see in the picture, the when we assess the airway, we need to see for the conditions which affect the each column, like any spine-related issues, arthritis, fractures, or cerebral herniation in the posterior column. In the middle column, you can look for tumors, foreign bodies, an extraphony, obstructive sleep apnea, retropharyngeal abscess. The anterior column is like a pyramid. Its vertices are on the temporomandibular joints, on the incisor teeth. Apex is on the hyoid bone. So the size of it is very important for us because we need a space to push the soft tissue structures to the one side during intubation. So in micropnea, the size of the pyramid is reduced. And in conditions like Ludwig's angina, malignancy, radiotherapy, the compliance of the soft tissue is affected. Along with this, we need to use other methods like Mallampati grading, temporomandibular joint mobilities, thyromental distance, and the mouth opening. And we need to look for radio images, CT scans, and in case of head and neck surgeries, they would have done a video laryngoscopy. So we need to go through the videos. Then finally, before planning for a intubation. So few basic things we need for intubation, which we struggle to get it whenever we go to the remote places outside our operation theater. It's like something like a suction, airway devices, which includes both nasal as well as oral airways. Different laryngoscopes. We need to, have different laryngoscopes with the different blades, possibly for all sizes, and video laryngoscopes. And depending upon our plan, we need to get arranged. Try not to experiment with any new scopes when you are dealing with a difficult airway. Tubes, try to keep all size tubes, and in case of any difficulty, try to use a tube which is one size smaller. And as for the medications, sedative hypnotics, depending on the hemodynamic condition of the patient, you can select them, or you can plan awake or under sedation or completely paralyzed. Analgesics will help to reduce the stress response. Relaxants, you try to give them only when there is an adequate mask ventilation, which is confirmed by visible chest expansion in case if there is ATCO2 adequate carbon dioxide curve. Muscle relaxant, rocuronium is preferred since Sugammadex is readily available in our institute. I think this everybody knows about this position. Sniffing position, which we use for intubation, which includes flexion at the lower cervical spine and extension of the atlantoaxial joint, which is easily achieved by just placing a simple pillow under the head, which is around 1.5 into 2 inches. But we don't get normal patients every day in our life. We do get patients like this. He had a huge swelling on the nape of the neck. We try to achieve some sort of a ramp up position with adequate cushioning and a lot of pillows. It's not actually a ramp up position, but we could achieve a good intubating position by padding. Pre-oxygenation, we need to replace the FRC with 100% oxygen to buy time for intubation. The traditional bag and mask ventilation, the issues are when we are doing the procedure, when we are intubating, there will be interruption in the oxygen supply. There's some like a Thrive is a recent advances. It's like transnasal humidified rapid insufflation ventilator exchange. So which maintains PO2 as well as PCO2 within normal limits even after 40-45 minutes of apneic ventilation. The advantages of Thrive is you continue to oxygenate the patient even during when you are intubating. So in case Thrive is not available, try to put a simple nasal cannula and an high flow oxygen, which acts as a CPAP also. So this girl was 13-year-old case of fibromyosarcoma. She has undergone multiple surgeries in our hospitals. I think each one of us have intubated her multiple times. The issues which we faced with her, like, she had an implant, her entire orbit, maxilla, nasal cavity, everything was removed. Her mouth opening was also restricted with just just around one centimeter, just enough to pass the blade of the video laryngoscope. So we struggled to mask ventilate also. Like what we did with this patient was we covered the orbit with the gauze pieces and we used the Thrive for pre-oxygenation. So then we confirmed the mask ventilation. Then we relaxed the patient and we intubated with the video laryngoscope with the appropriate size of flexometallic tube. We passed the magil through the orbit to guide the flexometallic tube into the glottis. We keep seeing these kind of patients in our OT. This fellow has undergone a ALT flap replacement for a CA cheek. The issues with him, he has a large soft mass in the anterior column. Complete anatomy is completely altered. And we need to take care of the vascularity of the flap when we are, planning for the mask ventilation. In any doubt, always plan for awake fiber optic intubation. Since in this patient mandible was intact and we could lift the flap, we tried conventional way of intubating the patient. We induced the patient once the mask ventilation was confirmed. We relaxed him and with the help of McGrath video laryngoscope, we intubated nasally with the appropriate size tube. This is a case of bronchopleural fistula post-COVID infection. It's a COVID sequelae. Patient presented with pneumothorax, surgical emphysema with mucosal edema. He was orthopneic, he was unable to lie down, and he was desaturating rapidly. So, okay, this is a video. Since we didn't have enough time, so we planned, direct awake fiber optic intubation in the sitting position. We intubated the patient in a upright sitting position without any sedation because he was completely tachypneic. So I could explain what I'm going to do to the patient. Luckily, he was very cooperative. So I'll just play the video. As was intubating, like his entire, the mucosa was swollen, edematous. Okay. The next case is, just a day before yesterday, I think yesterday we intubated in the ER. This is a case of array-epileptic carcinoma arising from the right retinoids, completely obstructing the airway. So we got a call that patient is in stridor. So we arranged for the fiber optic intubation. So we used 6 size the pediatric bronchoscope with a 6 mm internal diameter MLS tube. So I'll just go for a video. This mass is in the oropharynx and nasopharynx. We try to negotiate through the mass. We followed the shadows as well as the air bubbles till we reach the glottis. The vocal cords. Entered into trachea. During this, you can see the tube going in. Thank you. Okay. Thank you. Remember, like intubation is always a teamwork. There is no room for heroism, no room for ego. Always, keep a low threshold for calling for help. keep your seniors informed, have plan A, plan B, plan C, what you're going to do. If possible, inform the attending people or any surgical team if you need a surgical access. Thank you.
Good evening, all. I'm Dr. Sridhar from the Department of Critical Care. After having a discussion about all the guidelines and protocols, I need your participation when we have a case discussion about next is unanticipated difficult airway. When we face an unanticipated difficult airway, how do we proceed? I'll just take you through the couple of cases, and I want volunteers from the audience. So I'll straight away start with the case. So we had 62-year-old lady admitted to ICU with left-sided infracerebral hemorrhage. Subacute or subacute, and she was initially managed in ICU to ward. And in the ward, she developed sudden breathing difficulty, and she was shifted back to ICU because of desaturation. On examination ICU, she was found to have left-sided pneumonia with bronchospasm. So initially, we treated her for bronchospasm and for pneumonia along with the NIV. Initially, she could be able to respond well. She was able to maintain the oxygenation and airway with NIV. On day 3, what happened? She developed severe bronchospasm. She was unable to respond to the bronchodilators, even including the steroids also. So she started to drop her saturations and she was becoming more drowsier. Then we had no time. Then we had to make a plan and intubate her. We explained to her and we planned for emergency intubation. So what to do next? So emergency intubation was planned and she was induced with fentanyl, propofol, and oroquarim 50 mg. After we were able to do a bag and mask ventilation, able to maintain the oxygenation, so we can put able to ventilate her, and we tried to intubate her. So intubated, tried attempting intubating her with a Macintosh blade with size 82/7 size. We couldn't secure the airway. The Cormac line grade was 3, could able to see only epiglottis, not able to see vocal cords. So what to do next? Any after the guidelines, after the morning classes, anybody can tell what to do next? We are facing a unanticipated difficult airway. Couldn't secure the airway first attempt. Anybody can volunteer? Audience?
LMA, sir.
And here.
LMA, sir.
Second attempt with the Buji.
Yeah. We tried doing a second attempt with the same airway doctor, the different technique. We used smaller ICU with the Buji. So what happened? We couldn't secure the airway. We failed the second time also. The grade was 3. I could not see any vocal cords. It failed in second attempt also. So what to do next? That is the third step. So we're in anticipated difficult there we have planned. In ICU, we'll always in ICU and this scenario applies also to emergency and OT also. We may face this unanticipated airways. So we have tried intubating her twice with a different technique, alternative methods. Still, we couldn't able to secure the airway. So what to do? So we call for help. Always call for help. There are another senior airway doctor was there around. We could able to take his help. And second airway doctor was there. Then after second attempt, we could able to secure the airway with supraglottic airway, LMA with size 4. With that, we could able to ventilate her. Sorry. So able to ventilate, able to maintain the airway. So what next? This is an unanticipated airway in ICU. we cannot reverse the patient, we cannot awaken the patient. So we'll have to secure the airway at any cost. So what next, what to do? So we'll have to reverse and fully awaken the patient. Is it an option for us? It's not, you cannot do that one. So because she is having a severe bronchospasm, so she needs a definite airway. So we have secured on supraglottic airway devices. We could able to maintain saturation more than 95, 96. Then we went ahead with the front of neck access. So patient was able to maintain adequate oxygenation, and she underwent percutaneous tracheostomy by senior airway doctor. We could able to secure the percutaneous tracheostomy within 15-20 minutes. So the things to remember is so always call for help, have a plan, and follow the guidelines. Just don't jump all of a sudden to second, third step to fourth step or first step to the last step. So follow the plan, have a plan, or if you have a well formed plan, if the plan fails, have a second plan like plan B or plan C. So we followed the guidelines. We tried to intubate with 2 attempts. It was failed. Then we went for a supraglottic airway device. We could able to maintain the airway. Then, because we needed definite airway, we went ahead with percutaneous tracheostomy. So we always focus difficult airway on maintain difficult intubation. We tend to give less importance to difficult phase mask ventilation. This also becomes very much important. It is as important as difficult intubation. So difficult, the phase mask ventilation can become difficult. It can be graded into following grade 4. One is where we can able to do mask ventilation without any problems. In grade 2, needs assistance. Ventilation by mask is possible, but needs an device, oral or nasal air adjuvant. Then in grade 3, the mask ventilation is difficult, but it is inadequate or unstable and requires 2 providers. In grade 4, the mask ventilation is impossible. So these are also be taken into consideration whether we are using any muzzle relaxant or not. So this is the guidelines. I'll not go through again. So when this unanticipated airway comes into the picture, when after doing is all assessment, when we do history, anatomical, physiological or contextual issues were addressed and we've taken it and we predict easy airway, then we go ahead and the airway management becomes an important after induction of anesthesia only. So we induce them and we will face that unanticipated difficult airway in unconscious patient. So what will you do when you find a patient into inducing unconscious patient? We will find it difficult airway. So whether you can see whether we can maintain the oxygenation by mask ventilation or supraglottic airway. So if we can maintain oxygenation, then continue, try indenting the technique less than 2 times, different device or different operator. If it fails, stop there and think what to do next. Whether you want to awaken the patient. Most of the time in ICU scenario or in emergency scenario, it is not possible. And temporizers proceed with the supraglottic airway, then intubate through the supraglottic airway. If not possible, then really go for front of neck access. So if you cannot oxygenate after difficult phase mask ventilation or after assessing difficult airway, airway seems to be okay, but induced, but you cannot oxygenate, maintain oxygenation, what to do? So we'll have to go for directly for So if you fail, you have to directly go for front of neck access. So the 2022 ASA guidelines says that in parallel, before proceeding to the front of neck access, in parallel the preparation for emergency front of neck access, make a single final attempt. If any untried technique, like if you not tried proper face mask ventilation or supraglottic airway or tracheal intubation, and always ensure there is a proper neuroscope pocket is there. So then if it still fails, then you go for front of neck access. So this is the same algorithm which is already explained to you by Dr. Shweta. But just to highlight the same thing, if ventilation is inadequate, If ventilation is adequate, consider for call for help, go for a non-emergency pathway, use an alternative device, invasive airway, or awaken the patient, try. So here they stress upon 3+1 attempt. Play with the last attempt is like when you are not tried the different technique or different method, you go for that one. Maximum attempts are 3 or less than 3. If ventilation is inadequate, then it becomes an emergency pathway. You try adjusting the face mask ventilation, try getting in supraclavicular or tracheal tube. Either way can be possible. You can use a single technique or combined techniques. If still it fails, go for emergency invasive airway. They say recommend going for a rigid bronchoscope also. And they also say consider ECMO. So the major contributor for adverse outcomes in a difficult airway or unanticipated airway is preservation. A major contributor is to the bad outcome is the preservation. It's defined as repeated application of any airway management technique or two in 3 or more attempts without deviation or change. So don't take it as a personal ego or hurt if you don't get the airway. Always call for help. Try limiting your attempts. Always concentrate on your number of attempts. Always maintain the oxygenation throughout the procedure and call for help. So I'll go for scenario 2. I need to more participation of the audience. So I had one more 48-year-old gentleman admitted to the ICU with trauma. He had a slip and history of fall from height and sustained traumatic brain injury, a small contusion in the brain with surrounding edema. He was intubated in the ER and ventilated because of low GCS, was agitated, restless because of traumatic brain injury. So he was shifted to ICU. We managed well with anti-edema measures and other measures. On day 4, he was able to respond. GCS improved to 15. Could able to maintain saturation. He is successfully passed the weaning trials. So he was planned for extubation. We extubated him. So he immediately after extubation, he developed stridor. He became very tachypneic, desaturated, unable to maintain the airway within 10 minutes. So what to do? What this was an easy intubation in the ER. There was no difficulties. No difficulty anticipated airway was there. I was able to maintain the airway. Then we extubated him. Post extubation, we lost the airway. So what to do? Anybody? So we tried maintaining his bronchospasm or whatever the anticipated things with the bronchodilators and then tried NIV. With that also he desaturated further. So he was planned for reintubation. So with all the drugs in place, we induced him and intubated, tried intubating him. First attempt was unsuccessful. Was unable to pass the ET tube size 7 with the McIntosh blade 4. So unable to pass the ET tube. We failed first attempt, and second attempt was made with a different technique. We used the smaller tube. That was also unsuccessful. So what to do next? Anybody? So we called for additional help. So already 2 doctors were there. So till we called for additional help. So we made a third attempt. Then we could able to see vocal cords. It was a Cormac line grade 2B, where you can see could see able to the vocal cords, posterior parts, but it was swollen. There was like a slit-like opening, unable to pass the bougie also. So what to do next? We could see, but we cannot pass the bougie also. So what next best option is there to proceed with the airway management? Anybody want it? And just answer anything? Yes. We went ahead. We continued background mask ventilation. Could able to ventilate him. Could able to oxygenate him, but his CO2 went up to 65, 70. So we were to maintain the saturation more than 96. As sir rightly said, we could able to secure LMA size 5. With LMA, we could able to maintain oxygenation. So we had secured the airway with LMA. So next what? It is a difficult scenario where you cannot make him awake. We cannot reverse him back. We have to go back, go for proper airway. So we planned for front of neck access. We went ahead with percutaneous tracheostomy. We could able to do tracheostomy within 15-20 minutes. So all the time we were able to do a bag and mask ventilation. We were able to maintain the oxygenation, and LMI was inserted with ease. Then the So let's recap about when you face an unanticipated difficult airway in any scenario, ICU or be it an emergency room or be it in OT. So always call for help, optimize oxygenation. When appropriate, refer to an algorithm or use an cognitive aid. Definitely, you should have an algorithm, follow it. Upon independent unanticipated difficult way, determine the benefit of waking up a patient or restoring the spontaneous ventilation. Most of the time in difficult, unanticipated in ICU scenario or in emergency, it is not so possible. So determine the benefit of non-invasive versus invasive approach airway management, like using an fiber optic bronchoscope, video laryngoscopes. If non-invasive approach is selected, identify the preferred technique of non-invasive device, use the airway management device. If difficulty entered the each or individual technique, go for the combination of technique. Beware of passage of time. Just remember the passage of time, maintain the oxygenation and number of attempts made. Provide and test mask ventilation after each attempt when feasible. This is like a rescue bag and mask ventilation. You should be able to do all the time. Limit the number of attempts at intubating, so placing a supraglottic airway, thereby preventing damage to the injury or any bleeding. If an non-invasive approach is selected, where we cannot like becomes an airway, becomes cannot intubate, cannot oxygenate. So ensure that invasive airway is performed by an individual trained person whenever possible. Ensure that invasive procedure is performed as early as possible. And if an selected invasive approach fails or not feasible, identify an alternative invasive intervention. What does it mean? Means if you are training for an surgical tracheotomy, if it is not feasible, go for a needle or tracheostomy, whichever is comfortable. So the 2022 guidelines also include initiate ECMO when and if applicable and available. So there are my references. Thank you.
So good evening to everybody. What I'll be taking through is a commonly faced scenario in the ICU and especially in the wards. I happen to see some neurosurgery residents. I think most of them left. Is there anybody from neurosurgery? Any residents from neurosurgery? Okay. So we commonly face a scenario where we have a tracheostomy patient who has a tube block in the ICU. It happens in the ward as well, mostly neurosurgery, where we face a situation where tracheostomy is blocked and the resident, most of the times blockage happens in the night or in the early morning whenever the supervision is less and we have a difficult scenario. So I just, we not only spoke about the algorithm, we have an in-house algorithm how to manage such a scenario. I'll just take you through two case scenarios, how would you look at it and how I would like to have some participation, especially from the FMGs or any residents or ICU residents over here. So this is a case, we have a 50-year-old patient who had a road traffic accident, who underwent surgery for intracranial, he had a bleed and it was trauma, he underwent surgical decompressionectomy and subsequently he underwent tracheostomy. It was post-operative day 10 of a tracheostomy. He was on the ventilator because of the low GCS. We had difficulty in weaning, and he also, because of the tracheostomy, past 2 days, he was having some bleeding in the tracheostomy as well. So the scenario is patient in the ICU is on the ventilator. So clinically, you're seeing that patient is tachypneic, SATs on the lower side. It's about 88%. He's tachycardic, heart rate of 130. BP is okay. Patient is definitely having some respiratory distress. He's using his axillary muscles. Nasal flaring is there. He's sweating, and the nurse comes and tells you that doctor, I just tried to put the suction catheter and suction catheter is not going inside. So we have a custom tube block scenario here. So in the ventilator, you go to the bedside, you see this. Yes, you're seeing that the tidal volume is not getting delivered to the patient. You're just having a look at the monitor. It's in the early morning, and in the meantime, within a minute, patient saturation drops to 78%, and ventilator waveform is the ventilator is alarming, and you don't know what to do. So I want the ICU resident to answer. What is your next step? Anybody can contribute. So we spoke about the guidelines in the past 15 minutes back. Dr. Indumati spoke about the guidelines. So I want the ICU residents whoever is there can answer. What is the first thing we do? Yeah, that's the first thing. You will increase the FIU to them. Okay. Okay. The suction catheter is not going. So anything else you want to do?
With 15-liter water, we will have those.
15 liter, you want to ambu through the tracheostomy?
Right.
Okay. Call for help. Yeah, that is. What else you want to do? Inner cannula. So in the ICU, we don't use the inner cannula routinely. We use inner cannula. Maybe they use in the wards, but not in the ICU. So if there's inner cannula, the surgical team, maybe in the neurosurgery wards, they would remove it. But in the ICU, we don't have inner cannula. So yeah, okay. Anything else? Anything? So we spoke of the algorithm. According to the algorithm, what would you do? So this is the algorithm which was discussed in the 15-20 minutes back. So we have a tube block scenario here. First thing is call for help. Call your senior in the ward. If you have a tube block, call for code blue. If you patient deteriorating, don't wait. Call for code blue. All right. Supplement with 100% oxygen, as you mentioned. And in the ICU, always ask for an ETCO, end-tidal carbon dioxide, to look where the tube is, see how much is the ventilation, and remove the inner cannula if there's inner cannula in the wards, especially. In the ICU, we don't have the inner cannula, and try to pass the suction catheter. If you're able to pass the suction catheter, the tube is patent. Just ventilate, clear out more secretions, and just see if there's any problem in pneumothorax. Look for other causes. But if you're not able to pass in a suction catheter, you have a tube block scenario here. So the next step is, as Dr. Indumati mentioned, we have, if the cuff is inflated, sometimes the inflated cuff can abort the trachea. So just try to deflate the cuff and try if you can ambu and get some ventilation. But even that is not helping. If your patient is stable, saturation is okay, BP is okay, then you can change the tube. Use a bougie and change the tube. But if your patient's unstable, desaturate rapidly, like in our patient, you won't have much time. Just orotracheal intubation is the next step that you have to do. Just face mask, ambu, ventilate, and then intubate the patient. And later you can always convert it into a tracheostomy when the patient is stable. All right. So that is what you will do. So how will you identify tube block, especially for the residents who was working in the wards? You have a tracheostomy patient who was stable in the day, night. Suddenly patient is deteriorated. So you need to look for signs and symptoms of tube block. So patient may be tachycardic. So obviously there is no ventilation going on. They will be desaturating. So the work of breathing is definitely high. The patient is struggling to breathe. Patient will be tachypneic, the respiratory distress. They'll be using their accessory muscles. Nasal flaring may be there. If the patient is on a ventilator, patient will have reduced tidal volume that is not getting delivered. Peak pressures is one thing you look at. So you looked at the patient few hours back, the peak pressure was around 20. After 1 or 2 hours, this event happens. Always look at if the peak is high, either this tube block or there's a pneumothorax, so that you should think of. End-tidal will give you much information. There's no end-tidal waveform that you're seeing. Definitely there's a tube block or tracheostomy is in the false track. So, and the most important thing, inability to pass the suction catheter. So this is the waveform. So on the left hand, on your over here, you can see this patient peak pressure was 20. You're able to get some decent tidal volumes. About 400 you're getting delivered. So when this event happens, so you have high peak pressures. Always look for your peak pressures. See how much tidal volume is getting delivered. So obviously there is no ventilation at all. The tube is completely blocked. You have reduced minute ventilation. So this is an emergency. You will have to get the ventilation going, or else your patient is going to crash and have a cardiac arrest. So next step is also identify the tube block. You need to change the tube. So most of the tube changes happens in the ICU in a controlled environment, but sometimes neurosurgery residents, if the patient is stable, they do change the tube if it's particularly if it's the old tube. So the steps are first keep things ready, whatever use the smaller size tracheostomy tubes, difficult airway equipments. Attach always ask for an end-tidal carbon dioxide during a tube change. So if your patient is restless, agitated, you can use sedation, you can use neuromuscular blockers, new tracheostomy tube that is checked. So we recommend using a tube exchanger or a bougie. Don't even if it is an old tracheostomy tube, it is always better to change the tracheostomy tube with a bougie. Sometimes people try to use rice tube and guide wires, but those things are malleable. It becomes difficult to change the tube. Bougie or a tube exchanger makes it much easier to change the tube. So and always keep ready for backup endotracheal intubation. Call for help and keep your suction. Check your suction before you change the tube. So how would you change the tube? The first thing is if the patient is saturating. If all this you're going to do, if your patient is saturating well, if you have time so that you can change the tube, definitely you'll go for oral intubation. So first thing is if you want during tube change, supplemental oxygen through oral face mask and a breathing mask at high oxygen. So you cut off the ties, remove the gauze piece. Okay, so you're using a tube exchange here. Insert the insert the bougie or a tube exchanger. If your tube exchanger is not going, then your tracheostomy tube is fully blocked. Don't try to push the tube exchanger. So tube exchanger goes in. So you railroad the tracheostomy tube. Take off the old tube. You put a new tube. You secure it. Inflate the cuff and check for chest rise, end tidal, and connect to the ventilator. So use of bougie is what I was trying to stress upon. So in this scenario, tracheostomy tube was definitely blocked. You ask for help in your team members or in the ward. Call for a code blue if you can't manage the situation. This patient is definitely unstable, saturating 78%. It is a old tracheostomy tube, and if the patient is, you can orotracheally intubate the patient. The patient is stable enough, then you can try to change the tube with a tube exchanger. So if you're not able to pass the tube exchanger, always you would remove the. If the tube is blocked, it's not able to ventilate, just take out the tracheostomy tube and intubate orotracheally using the later you can always convert it into a tracheostomy. So one more case scenario we'll quickly go through. So this is another example. The patient had a RTA. He underwent surgical decompensatory and underwent a tracheostomy. It was early tracheostomy compared to the first case on the second day. And in the ward, he was desaturating. There was tachypnea. The neurosurgery resident thought it is tube block. So the suction catheter was not going. So the resident tried to change the tube. So tube was changed, and then even then the saturation was not improving. So the patient was shifted to the ICU. So once the patient came to the ICU, this was the situation. The patient was very tachypnic, breathing at around 50 per minute. Saturation was 88%. His BP was okay, very tachycardic. And in the ICU, we tried to insert the suction catheter, but it's not going into the trachea. It's not going inside. So we have a tube block scenario here as well. So how to manage this situation? So similar to the previous protocol. So we discussed the tube block scenario. If catheter is not going. Compared to the first case, this is early tracheostomy where the risk of false passage is much higher. So it might have gone to the false passage. The tube is definitely blocked. You secure the airway. If patient is stable holding on, you can orotracheal intubate. If not, you can try to because in early tracheostomy, that maybe in the false tracks, always it's riskier to change the tube. So if there's no surgical, call for help from surgical team. Your whoever's there in the ICU or in the wards or in the surgical ICU, call for the backup. Always call for help. So in this, it was early tracheostomy, and patients who have when the track is not mature within 5-7 days, always there's a risk of a tube block. So if there's a risk, if there's a suspicion of tube, always remove the tracheostomy tube. You can always use ETCO2 monitoring to confirm it. So perform endotracheal intubation, secure the airway, and later you can always convert it into a tracheostomy before you lose the airway. So I wanted to conclude. So whenever you face a tracheostomy tube block scenario, always call for help wherever it is, call for help. Identification of tracheostomy tube block causes signs and symptoms which I mentioned. So especially in the ICU on a ventilator, identification of tube block is important. So you always try to change the tube with a tube exchanger or a bougie. Try to railroad. Don't just blindly take out the tube and put a tube. Always use carbon dioxide monitoring and endotracheal intubation always work. Don't try to keep on trying to change the tube. In the meantime, you have a desaturated patient, you'll have a cardiac arrest. So if you're not confident enough, if patient is deteriorating, always intubate the patient. Then later you can always secure the tracheostomy related. So I wanted to stress upon the use of bougie and identification of tube block in the ward. Especially in the ward or in the ICU settings. Thank you.
Thank you, Shiva. Sir, any concluding remarks from the moderators?
Okay, it was a nice presentation by the anesthesia and intensive care team. Very important topic. We try to think of the patient who is, cannot intubate and cannot ventilate, and we are given a guidelines how to go about these cases. Having a proper plan will mitigate most of the complications. But of course, there are situations wherein we get into very rarely we get into a situation where we may have to use the invasive airway, and best thing is to call for help early. And also when you are going with the invasive airway, you need to have people who are experienced in that, especially you have somebody who is expert in tracheostomy who always deal with that. It would be nice to have. With that, it was a nice discussion. Thank you.
We had a very good topic and a very good discussion today about difficult airway. And whenever you anticipate any difficult airway, you can always use either rocuronium or vicronium. So you can quickly, suppose if you are not able to intubate the patient, we have a reversal agent available now. So that's called a Sugammadex. So you can give it immediately and you can reverse the patient and you can, make the patient alive. So that's a very important. So whenever you face that situation, anticipated difficult airway, please use rocuronium or vicronium. Then always, try to see the airway by video laryngoscope. So that will, make the life very easy. And try to use the angulated bougie. If you are using a straight bougie, it will go and hit the posterior aspect of the arytenoid, and you will not be able to intubate the thing. You will have to imagine that 3D image of the airway. So it has to be angulated and it has to go in a particular angulation. So then only 100% success will be there with difficult airways. That are some of the few techniques we use. We also encounter a lot of difficult airway inside the OT also, but we intubate the patient with all this burp, positioning here, the backward, upward, rightward pressure of the larynx, and use of scopies, video laryngoscopies, and we use this angulated bougies. So we could achieve most of the time, but we also face sometimes we can't do that. There are very few times we could not intubate the patient. We need surgical access to secure the airway. So there are, see, this algorithm is most of the time will rescue the patient. We should follow this algorithm. This algorithm is broadly gives a difficult airway management. But for each patient, you will have to think about it and you can use it. Suppose if you are using for this pediatric patient, it's a totally different scenario. So you can't use all these things for the pediatric patient, and you'll have to think a little differently and to do that one. There are smaller sizes tubes, smaller size stillets available, and even you can call for pediatric surgeons help in pediatric difficult airway using the MLB, that rigid bronchoscopy also we can try sometime. Through that we can pass the guide wire, and through which you can railroad the endotracheal tube. That all not mentioned in most of these algorithms, but you need to know. And there are some of the sandwich techniques are available. Suppose you can ventilate the patient, but you can't intubate the patient scenario. So where you can put the LMA, but you cannot proceed with that LMA the whole surgery. So what will you do? So you have a sandwich technique. So where you can use the video laryngoscope. The second operator can use the fiber optic bronchoscopy to push, put the tube, fiber optic scope through this video laryngoscope guidance into the trachea and pass the tube through the trachea. So this is called sandwich technique. So that also you can try and do that one. But those things are all not mentioned in many of these algorithms, but you can try and use those techniques. With that, I think most of the topics related to the difficult airway is covered. If anything, Harish, you want to highlight about the difficult airway?
Actually, as I said, we can like for all the difficult intubations, or when you're alone, or if you're not comfortable, or if you're not trained well, better to use like what is that, vecuronium or rocuronium, because like now you are like since last 1 month we have Scubadex, so that you can reverse patients immediately. And second thing is like whenever possible, try to use this video laryngoscope in your routine practice, so that it will be easy for you to face difficult situations. And fiber optic bronchoscopes actually is less mentioned, and like everybody will get to train for fiber optics, and it is a really life saving if you are trained in fiber optic. But training is very important for everybody, like listening, and it is like learning bicycle by reading a book. Okay, it's not possible.
This algorithm is not made for Narayana Hridayalaya, but see, see, Narayana Hridayalaya, nobody uses like this. We very rarely use this kind of thing. See, most of the time in pre-assessment itself, you identify the airway difficulty, and you will go through the awake fiber optic intubation. So the more emphasis is given on the awake fiber optic intubation, how to prepare a patient for awake fiber optic. See, awake fiber optic intubation is not an easy task, securing airway by fiber optic intubation. So you will have to prepare the airway, counsel the patient, topicalization with the appropriate local anesthetic. You should not exceed the toxic dose. And all that thing very important. That itself makes a bigger discussion on a topic. So and at the same time you keep the patient well sedated, calm, and listening to your command. And at the same time, you should not put the patient in too deep to stop the breathing and arrest. So that's very important of use of awake fiber optic intubation. the algorithm and most of the guidelines, it's just one point is mentioned at the awake fiber optic induction. But that thing, if you are slightly anticipating, suppose see a buccal mucosa or any growth in the vocal cord, piriform fossa growth, no, the most of the time you can anticipate this one, and you can do this one with a fiber optic awake fiber optic integration. And again, not all the time awake fiber optic intubation is not successful. That also causes a lot of complications. If the tumor is easy to bleed on touch, then you will have a more problem. You can't see anything. If easily, everything will be reddish there. You should be very smart and very careful about handling such scenario. So if in such a scenario, if the vocal cord is very small, the opening is very small, it will only allow some 5.5 or 6 size tube. If you are trying to use with some 7.5 size tube or with the adult fiber optic bronchoscopy, you will mess up that case. There you will have to choose the pediatric fiber optic scope and use the smaller size tube, and you intubate the patient. So that all those the decision making is very important in what fiber optic bronchoscope you are using for a difficult area also matters. So that makes some and always the airway trauma case always makes a lot of difficulty for the anesthetist. That by awake fiber optic you can do that still.
Awake fiber optic is not stressed here in this algorithm, mainly because this is an unanticipated difficult intubation we are faced with and how to proceed. Because in an unanticipated difficult intubation, because airway, managing fiber optic intubation is difficult. So that's why it takes time and it needs expertise. So that's why that is not stressed upon. Of course, once the patient is stabilized with oxygenation and ventilation and you wake up the patient, then the next plan of action for that patient would be to go ahead with an awake fiber optic intubation, but not as an emergency situation. Thank you.
This Thrive and high flow oxygen and your McCoy scope plays a very important role. It was not mentioned anywhere, and it can be part of your difficult airway cart. McCoy is a real useful one. Then all the patients, I feel you can use Thrive in whenever in a difficult situation. Definitely, it gives you extra time for intubation and to maintain the saturation and all those things. One, if you have relaxed, actually many times myself and Murugesan, like after relaxation, if we find difficulty in intubation, somebody will put the scope and somebody will put the bronchoscope. Like two people need to do that.
I think it's a very good equipment that is available, especially when you find a difficulty in ventilation or intubation. Put the patient on Thrive if it is available, so that it will give you more time to secure the airway. Now, since 3 decades, there are so many changes that have taken place. All these things were not available about 30 years back. So we have now video scopes, we have fiber optic bronchoscopes, we have Thrive to prolong the oxygenation, but still it is scary to see a patient who is in a difficult intubation when we cannot intubate and we cannot intubate.
And here in our hospital, if I find myself difficult in airway, I would like to call ENT or head and neck people as first for help rather than colleagues, because like they are the one who will be good at surgical airway handle better here in our hospital.
That is at your level, sir, but residents, I think, should fall back.
Okay, thank you. Any questions from the audience? Anything? Any doubts, any suggestions, clarifications?
How frequently have you used intubating LMA to?
Intubating
Intubating LMA is, you can just pass some 6 size.
Yeah,
intubating LMA is tube. And then over that, you can put a bougie and then change that to a larger tube if required. Intubating LMAs are available with 3 size, 4 size and 5 size. So when you just ventilate with LMA, you put the intubating LMA and through that you can pass the tube. Itself. 6 size tube, 6.5 tube can be pushed through.
Any role of these combi tubes, here, these combi damage?
It was only
in the ACL.
CA question.
That is
No, we didn't use any, we didn't see, I didn't see first.
It is not mentioned anywhere. Not mentioned anywhere. It's not
No,
mentioned.
it's not in any of the algorithm, it is just.
I think very rare
One of the
being
tube which was used.
I think it's also a supraglottic airway type of a thing. If you can use it, you can probably try it.
Even in supraglottic airway, actually you can give a try with tube exchanger, try to pass that through the supraglottic airway. Sometimes if you are lucky, it goes through.
The ILMA, the intubating LMA, the problem is you pushing that tube and negotiating and pressing it and removing all that is little cumbersome.
We try with.
And it is in the beginners or inexperienced people, it's very, very difficult.
Yeah, similarly, the video laryngoscopes also, sir.
Yeah.
Kids, the residents should not directly try video laryngoscope if that is the first time they're using the video.
Yes.
Because they will definitely not be able to put the endotracheal tube in place. So probably would encourage the residents if, probably in the theaters, whenever the regular intubation, they should, as Harish sir mentioned, we should probably regularly use the video laryngoscope so that they get a hang of before trying it on difficult air.
If it is resident who is trying the intubation, but just before intubation, first to see a neck extension, the allotment of the airway, if you can just move the trachea left, right, then that much of movement, if it is there, you can give some anterior pressure and put bougie easily in there. Another mistake which most often happens is the pillow which is left is under the shoulder. That should not happen. It should be just below the occiput. Then you get a nice lower cervical flexion, which prevents difficulty. Most of the men, sometimes it is made difficult than what it is. By this improper positioning of the patient. Because in most of the ICU scenario where you're just.
Yeah, ICU is a bad place.
There's no pillow also and the patient is lying extended. So there, as you put the laryngoscope, the larynx goes further anterior. And most of the time you will end up going inside the mouth to find out where the larynx is.
Good. So, thank you so much, and it was a very good interactive session. Thank you.
Yeah, thank you speakers for getting their time in preparing PowerPoints. Thank you moderators for coming here in spite of your busy schedule. And thank you audience for joining us. We have a snacks to be served. You can join us in the snacks. Thank you.
Thank you.
Thank you.
Thank you so much.